It's my pleasure to invite the next speaker, Professor Rupesh Raina, to give us a talk on how to break the cycle in recurrent FSGS. Over to Rupesh.
Sorry, if I stand, I will be too tall, but I'll try my best I can and move the podium. Good afternoon, everybody. I just was given a little tough task about recurrent FSGS. And before, if I start the talk, I don't know that I get the answer what works. But I'll try my best. I'm going to talk about the post-transplant recurrent FSGS. We have a nice guidelines. You can see the research portfolio with me looking at the answers for the recurrent FSGS is still a dilemma because nobody knows what is initiating after the transplant. If you look into the recurrent primary renal diseases, these are some of the incidents. And if you look, FSGS is high, not as compared to the MPGN1 or MPGN2. Graft loss is higher and almost comparable to the now. You have to look at the USRDS database and UNAS. And we just updated our recurrent primary renal disease after kidney transplant UNAS database. Dr. Lars Pape is here. This is our initiative for our IPTA education, and we are going to submit, which is presented in the IPTA. And what it shows is it's still type 2 mesangiocapillary GN has the highest recurrence rate at 20.6%, followed by FSGS, which is now 15%. So there's a change in the paradigm. Maybe you're identifying earlier as compared to what it was in the USRDS. And if you look at the post-transplant FSGS, still there is a mystery. And I'm not going into detail. I'm not a molecular biologist. There are multiple pathways which is initiating. Initially, there was a concept of SUPAR. Then that's kind of not proven in a transitional medicine. Then they were saying it's not SUPAR. It could be CLSCF, CD440. It could be a proposed podocyte pathway, because they were thinking maybe it's a problem with the podocytopathy. Then there is another speculation came out. It could be a cytokines, which I believe is the cause of post-transplant, because somebody is priming the factors to cause the porosity. And that happens like within 6 to 8 hours, sometimes like 12 hours. Then they are saying there could be a potential antibodies and anti-nephrin and anti-UCH L1. And overall, I will again say that hypothesize immune-mediated podocyte injury leading to FSGS. There's a priming after the post-transplant where you see the recurrence. And there's a lot of data coming around from the multi-institutional study. We were part of that too, that there is circulating anti-nephrin antibody are possible candidate for the circulating factor in pathogenesis post-transplant recurrent FSGS. This is what I have proposed because it is very complicated. I like the FSGS, which happens within 24 hours after the transplant. Clean, chemokine mediated, priming. But if you look into the post-transplant, like 6 months later, you have presence of other diseases, T-cell mediated rejection. Then you have other coming glomerulonephritis, whether it's an endothelial injury, whether it's a podocytopathy, whether it's a detachment of podocyte, whether there's a proliferation of PEC, it gets more complicated. And I put some of the mechanism of the FSGS there. When we were writing this guideline, it took us 2 years because there's an adult and peds they were fighting. The issue was peds said steroid resistant nephrotic syndrome should be considered as FSGS. And I think 2 of us were on the side. We said, it is a different spectrum. FSGS is FSGS. You cannot blend this. Finally, the guideline published in KI. But we must have moved forward before we can significantly impact outcome of renal transplant. This is the diagnosis, which is very well defined: massive proteinuria, hypoalbuminemia, and adults the same thing. And the criteria, I love the guidelines because at least the diagnostic part, we were very good with our evidence. Now, if you look at the histology, Dr. Randhawa, I don't know how much you people know, he's a guru of the primary recurrent GN, and he's in Mayo, and he defined this FSGS very well. Type 1, recurrence of the same variant of FSGS in the native kidney, recurrence of the same variant of FSGS as native kidney following an intermediate minimal change like lesion. Type 3, recurrence of diffuse FSGS variant that is in the native kidney. And actually, we are going to look at the data on these histological features and see what their outcome is. Incidence of FSGS is variable, as I just showed you in our UNOS database, which is up to date, and it's 15%. It is increasing. Compared to Caucasian children, African American children are more likely to receive diseased donor kidney allograft with poor HLA matching or experience acute rejection. These factors may explain, at least in a part, why FSGS is reported less frequently in the patient population. This is a paper for the incidence, and it is now higher going into the UNOS is around 15 to 16%, which is 21 is MPGN. So they're kind of coming along more early. I think just there is an advancement on the dialysis, advancement on the transplant, and maybe now we recognize this entity very clearly, at least as a post-transplant. This is another paper that we looked at the UNOS. It was a podium presentation in Kidney Week, where we showed the recurrent FSGS database is still pooling, again, a part of our IPTA Education Committee initiative, and we are also doing a label box. Maybe we'll come up with some risk prediction. Recipient age was associated with the reduced recurrence-related failures, but an increased risk of other cause failure. Living donation was associated with increased risk for reoccurrence while being strongly protecting against other failures. These are the clinical factors associated significantly higher hazard ratio, dialysis at the time of transplantation, living donor kidney, rituximab induction, extended dosing criteria. Conversely, older recipient was found to be significantly protected against reoccurrence. So the whole paradigm changed now, and this is a very favorite questions for a board. What are the things that prime for the reoccurrence of the FSGS? Now, this is risk factors: prior recurrence, rapid ESRD, living donor transplant, mesangial hypocellularity, and Caucasian race. Stronger predictor is late steroid resistance FSGS. And this is a risk factors. We recommend close monitoring, and we recommend as soon as the transplant is done in a high-risk patient, we recommend additional estimation of UPCR on the day after the transplant, day of discharge, once a week for 4 weeks, and finally once a month for 4 months. This is what I like put in the guideline. These are the factors that are reported to be associated with higher risk of recurrence as follows, and I am lead it everything what you have. Now we are going to go back to our UNOS database and look what the factors, and maybe we will develop a risk prediction, because in IPTA now we have an AI section. Thanks to Dr. Lars Pape when he was a president. We are going to have AI section with me and Evgenia Prekel from France group from to look at what are the AI part we can bring into the consideration to look into it. Live related versus disease donor, very controversial. What I will say is that live donor, the pool incidence was 22 versus disease donor, it was 21.85. Pool odds of recurrence FSGS was significantly higher among living donors or compared with diseased donors. Although the odds of recurrent FSGS higher in patients with receiving live donor grafts, the incidence rates are comparable. Hence, we suggest tailoring the type of graft in according to the patient needs. So we are not going for live donor versus diseased donor. These are some of the biomarkers, and I really like this slide because you have the injury mechanism, you have circulating permeability factors, you have T-cell mediated. And love the slide on this one, which tells you exactly it's a multifactorial. It's just not one thing that can prime you to develop a recurrent FSGS. Plasmapheresis definitely has shown response because there is something which we are removing. Don't ask me and put me on the spot what it is, but definitely you see the response. And these are all the biomarkers. And we put in our paper, these are all TNF, chronic gonadotropin, ribonucleic acid. And this is a very good paper. They came out with a fast antibody panel in recurrent FSGS, the predictive accuracy of subset of this panel. And they have taken all these biomarkers and they created area under the curve. And this is what we are going to look. Unfortunately, we do not have all these biomarkers available at every centers. And again, same thing, amount of selective proteinuria. Selective proteinuria is you fragment albumin to creatine and protein to creatine ratio. And if you have a higher albuminuria, then you have a higher chances of the recurrence. And again, cardiotropin-like cytokine factors is a candidate for the FSGS permeability factors. And this is a little promising. It's transitional now because if you can block, you can have the effect on reducing the proteinuria. What is in horizon? You have SUPAR, which has been not shown very well in the transitional model. Cardiotropin like CLC1, very promising, but again, we need to see autoantibody to anti-CD4 antibody, which is predictive of the accuracy of recurrence. And they are talking about vasodilator stimulated phosphoprotein podocytes, which has shown, and this is a development of novel cell-based assay to diagnose recurrent FSGS. I'm not going into detail, but just want to show you how the selection of the candidate gene and identification, maybe we can predict which patients can reoccur. Importantly, there are multiple biomarkers. Our guidelines did not say to follow one or not, but again, selective proteinuria is very important. There's some gene encoding podocytes protein, and I think this is very important for you to know, and I put a very nice slide because this will come up all the time when you have a donor. I said genetic FSGS usually does not occur because disease originates from a defective podocyte gene, not a circulating factor. Therefore, genetic testing help in risk stratification, counseling, donor selection. APL1 and its implication, risk factors common in individuals with African ancestry, increased allograft failure, not associated with recurrence, but avoid high-risk APL1 donor in FSGS when possible. NPHS1, key genetic exception, classic is Finnish type congenital nephrotic syndrome. After transplant, recipient may form anti-nephrin antibody against WT donor nephrin, leads to reoccurrence of 25 to 34%. So I think this slide is very, very good for you when you're sitting and accessing, and this is what the genetic panel application is: easy access, help differentiate, allow better reallocation. But again, the jury's out. We don't know what it is. Beyond biomarker, accurate identification of patient with high risk will aid in counseling patient on their risk, creating individual treatment protocol pre and post transplant, designing clinical trial to prevent treating nephrotic recurrent FSGS is what we have to do. How to treat? This is a European Society of Pediatric Nephrology survey, and this is just very much laid down. What they said is 63% applied a similar regime to the patient with known mutation FSGS recurrence were treated by the PF or the plasmapheresis versus the immunoadsorption. Plus, by 66 of the respondent and 54 observed no response. So it's kind of not very clear. And this was done in 2019. I think we need to go back and look in the overall survey how people are doing and treating it. This is KDIGO guideline, very disappointing. Very disappointing. Very generic. And when we were doing our guidelines, I think Dr. Yap was also involved with Dr. Cha, and we were discussing this is so basic. You have the proteinuria treated, where you go, you don't know. And this has got a little bit better in the ATS, and they come up with this, the same thing, measure 24 hours. Everybody was talking about diagnosis, but nobody was giving us a protocol how to treat, because this is something tough. You need to act fast. So this is our protocol with plasmapheresis, immunoadsorption, rituximab, and cyclosporin, and renin-angiotensin system blockade. And our evidence was pretty strong, 2B, 2C. This is the best you can get in peds, so you're not going to get 1A even in adults. So we were very clear how much plasmapheresis we want. We talk about immunoadsorption, we talk about cyclosporin, and we also talk about rituximab dose. And we recommend early initiation of plasmapheresis in patients with nephrotic range proteinuria following transplantation. The regime is daily plasmapheresis for 3 and then 3 times a week for 2 weeks for total 9 treatment. Why we did it as a 1B? Because I'll come to the other slide, because I know Siddharth is going to ask what are we doing for LMIC, and I will address that question very soon. We suggest exchanging 1:1.5 plasma volume using citrate or heparin anticoagulation. Following initial therapy of recurrent FSGS with plasmapheresis, the degree of proteinuria should be assessed, and the need for and frequency of additional sessions should be determined based on the patient response. Immunoadsorption may help with PE in patients who successfully responded to initially plasmapheresis. And immunoadsorption should be 2.5 to almost like 3 plasma volume is done every day for 1 week, followed by tapering alternate for 2 weeks, and bi-weekly for another 2 weeks. So I like really our guidelines that we publish in KI is we have a clear indication for you. We are not just leaving you hanging around in between. This is a new guideline that came up for indication recent evidence of apheresis in children and adults with kidney disease, a comprehensive review just published in CKJ. And this is a nice paper by the group from Riley, and what they have shown was in about a cohort, they have a recurrence rate of around 26%, which was 15% in our UNOS, and age of diagnosis was 3.4 versus 9.2 no. Recurrence, living donor were 57%, remission with plasmapheresis was 86%, and their average plasmapheresis sessions were 50, range 21 to 61. Average duration was 141 days, range 54 to 93, and if 193. If you guys are all in Pete's Nephilus, there's a lot of hot topic going on. Keep on doing plasmapheresis till you see the reduction or you are happy with the proteinuria, and this is a good paper to be there. This is therapeutic plasma exchange in recurrent post-transplant, and this is what we are saying is frequency, initial, duration, and volume. Intensive, then you can go 2 times a week, 1.5 with the PV, and early final maintenance, weekly, monthly, up to 9 months. So the data is coming around 9. So don't give up, keep up going. And that's a lot of controversy back and forth, and that's why the data is there. This is our database that we shown that early plasmapheresis continuing longer till you go into remission is workful. This comes open up the whole extracorporeal therapy, which is I was the one with the group to start the extracorporeal, which is known as the lipoabsorber, and we did the study basically with the steroid resistant, and after that we actually moved to the focal, recurrent FSGS. There's a national data there. This is LDL apheresis, is basically an immunoabsorption, and what it does is this helps in recovery of macrophage function, prevention of proximal tubular injury, enhancement response to immunosuppression, prevention of vascular endothelial injury. It was effective. This is how it happens, and actually if you see the apparatus, the first time when I did it on a recurrent FSGS patient, the 2 columns of this heparin-based site selection electrostatic interaction, it has removed all LDL, VLDL. Within like 20 minutes, it was mac and cheese, the whole apparatus. I was like, wow, they're absorbing. And if they can remove LDL, technically, then you can remove any of the biomarkers that you're talking on. And I'm not committing and not selling any one of them to you. I'm just saying there's some chemokines which you can remove. And that was why lipoabsorber as direct hemoperfusion reduced. And this is how the system is. It works well. There's a lot of data coming along, and this is our final paper that came out very soon in the Hemodialysis International. And actually, the LDL apheresis is effective in 50% of the patient. And this is our low-density lipoprotein apheresis for recurrent nephrotic syndrome. This is a paper we did a systematic review with Dr. Priya Varghese, and this was presented actually in podium in IPTA. And what it shows is the complete remission is 46, partial 38, no response 16, and overall response rate was around 84%. And this is just a systematic review of the published data. We recommend using rituximab in a patient who have contradiction to plasmapheresis or immunoabsorption. And we gave you the dose. We recommend doing hepatitis B, C, HIV virus prior. Plasmapheresis should be withheld for 48 hours following each rituximab infusion to promote drug. This is our algorithm that we put it in, and I don't have time. It's a very busy slide, but I love this protocol. And trust me, it took us, Dr. Yap, I think 2.5 years for this table, fighting, and there was a boxing. I was a referee, peds on one side, adult on one side, both won. I gave them a vote to both, but it was a big fight on this table, multiple corrections, and I still counted, which was like 192, 193. And this is how you initiate the plasmapheresis, what do you do for immunosuppression, immunoabsorption, how many hours you do the TPE, or what is the protocol. Now, advances in recurrent post-transplant therapy, FSGS, emerging therapies coming along, which is daratumab, anti-CD20, anti-APL therapy, complement blockade. These are just small case studies here and there. And this is how the LDL apheresis occur. And now, going back to Siddharth's question, and most of the time when I did this presentation in India, people all stood up and said, we cannot get lipopheresis. Well, that's not my fault. I don't run the lipopheresis. It's an FDA, they have the recommendations. So what we developed with India protocol is to use double fill DFFP. And we have a paper that we submitted is in LMIC country, how are we going to manage the FSGS? And DFFP came out as a solution. I think, if I'm not wrong, like 9 people are enrolled, 9 so far. We are working with the group, and we'll give you a data. At least this is better than using the plasmapheresis. This is a pediatric paper with subcutaneous ofatumumab. Oh my God, I just get this this stubborn, like hard to pronounce, but the data is out, very sporadic, and soon in March in PNRC we are going to propose a study to see what are the new therapies that really working in FSGS to look at. This is a trial going on with rituximab and plasmapheresis. They want to do it before the transplant and then start the process after with a high risk, but we'll see. The enrollment is very poor. And again, you have ACTAR, which I have done a lot of work in FSGS. You have anti-cytokine plasma factor therapy. You have cell-based novel therapy. Conclusion is that it is a tough disease. I like when there is no confounder, it occurs at the time after the transplant. It's a clean chemokine response, and at least you do the plasmapheresis, you do the plasma exchange, you can get better over the time and treat it with rituximab. But when it's more than chronic than an acute, then it's really get difficult because the multifactorial things come into place, which I showed you in my slide. I think we did answer some of the questions on this primary recurrent FSGS. Guideline is very clear, direct, with doses, and what can be done was all there. But I think we need to go back after a year or so to revise it, to add some of the new therapies which is coming in horizon. And unfortunately, I get a lot of recurrent FSGS in my center, and I don't know why. We do lipophoresis. It's really a nice therapy to do, but very expensive. Hopefully we can get it to more the LMIC countries or other places, but it's very hard with all the Kaneka is a Japanese form. I don't know what their restrictions are. So far it's going well in US. A lot of people are using lipophoresis, but definitely new thing that we develop is a DFFP for at least in LMIC country to combat the disease. With that, I want to thank you and really want to thank IPTA for giving me an opportunity to the education forums to develop such kind of studies, and definitely will come up with some of the answers if it is available. Thank you.